our plan, what we thought was we'll do, we have the microcatheter also, right? No, we are ready to load it. Okay. So we'll cross with the wiper wire, then do orbital atherectomy, then do imaging, because even in the caudal view, the shows the caudal view, the left main appears to be mildly diseased. So we'll evaluate the left main and then decide whether we need to cover till the left main ostium or stent the LED alone. The angio done. Today the caudal view seems as if the left main is looking good. The distal left main also looks good, but then the other day during the primary angioplasty, the angio done revealed that the bifurcation was mildly diseased. Okay, we are gone with the microcatheter across. Now we'll take it out. Vishnu, is it 3 guide or 3.5? 3.5. Yeah. No, in fact we wired with the run-through wire. Now the microcatheter is down there, so the wiper is going through the microcatheter. Will what way will be benefited anyway? We are planning. It's so much of calcium. It's so much of calcium. We are anyway planning for a orbital. ഇവിടെ തന്നെ ചെയ്യാം. Vishnu, should we wire the diagonal? Because LED is much more diffusely diseased. Can we park the wire in the diagonal? Shall we see the first image, first epicranial image, so then we can decide whether... Just run it and show the distal portion of the diagonal. But it will be safer to have it in the LED. Huh? No. Till the septal. That's the plan. Like till the septal. Vishnu, we'll again come back and go into the main LED only. That's safer. Give a torquer, rotawire torquer, so that we can manage it. Somebody give us a rotawire torquer. The diagonal looks less diseased, isn't it? So shall we go into the diagonal? Because this ultimately at the end of the procedure we might close down the LED. Diagonal looks reasonably better than the... We'll go into the diagonal. Let it go much. Okay, that's... Okay, that's good. We'll take the microcatheter out, then go with the... Okay, so next run once again. Actually, that calcium is in more it's in the proximal LED, and it's reaching till that particular septal. So we'll probably do that entire calcium and then stop. LM is also calcified. അവിടെ ഒന്നും ചെയ്യാനില്ലല്ലോ. Okay, so we'll check the check the device. Okay, so we'll check all the parameters. We'll have the lock knob, lock, then we'll check the speed. Vishnu, പൊക്കി പിടിച്ചേക്കാം. We'll check the speed at 80,000 RPM. Okay, that works. Now we'll go in. We'll go in. It should be in the distal one. So that once we start burring similar to the rota, you can pull it back little bit so that the tension that builds up would prevent it from jumping into the coronary. But then that's usually not an issue. It will come back. It wouldn't get stuck most of the times. Okay, now we are ready, Vishnu. Okay, we'll lock the wire. We'll go at 80,000 RPM. Okay. Those areas. That's the main calcified area. Be ready with a 2.75 balloon at least. In fact, compared to rota, if you decide on orbital, any day you can start off. You don't really need somebody to help you out, things like that. It's such a user-friendly device. The troubleshooting is significantly less. The same device we've been using from morning. If had it been rota, so many challenges you would have encountered by this time. Okay, we'll go. Till there, avade. But there we are not seeing, hearing any change in pitch in the distal portion. If so, proximally, get a 3 balloon rather than a 2.75 balloon. Higher pressures, higher speeds. Now we'll go at 120,000 RPM. Give us a New York run-through wire. We'll do one more and stop. Once we are done with this, we'll go with the run-through wire again into the diagonal branch and then do an OCT pullback. And then to decide whether we should be stenting the left main or just the LAD. While wiring the LAD, we'll have the radiopaque marker to see the length of the lesion also. It's, or should we go for one more run? No STT changes. One more. We can always do that. The problem with not the problem with creatine. The problem with rota, while doing rota as well as while doing this thing. This is the sleeve is actually 3.5 French. We'll do it. Yeah, it's 3.5 French. So it will be mostly occupying the lumen of, even though it goes in easily through a 7 French catheter, it will be occupying the entire lumen. So when you move this forward and backward, there is always a chance that because of Venturi effect, you tend to have small air bubbles inside the guide catheter. When you take the sleeve inside, when you take it out. So as far as possible, in between, if you don't see significant STT changes or if you don't see hypotension, better not to inject. But we'll be tempted in between wait and, but while doing rota, we never try to do that unless it's really indicated. Let it come. Slow. One. Okay. Okay. ഒന്നില്ലേ അത് അവിടെ വെക്കാം. We'll go with the New York run through wire. New York run through wire. We'll give some nitro and then do an OCT run. Huh? Come caudal. Can you come caudal? Okay, come cranial. We'll give some nitro and then okay. We'll take out the other. Okay. OCT. We'll do Selenus. ഒരു ഇതങ്ങ് ചെയ്യാം വിഷ്ണു. Final shoot will do. Okay, pressures are okay. Fisheye is okay. Calibration has been done. $20cc syringe. Okay. It's not saline. It's not saline. Oh, yeah, that's saline, huh? Okay, then give that. Okay, ready? Saline. But then we'll have more of saline here. Okay, I take 50. Okay, ready? Jojo, you should activate it. Okay. Yes. We'll take out the catheter. It's a regular hep saline. Hep saline. Hep saline. Hep saline. Yeah. 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 The image is quite good. But then the data says that Ankush Gupta had presented that in their series there is no difference at all. There is no difference at all. Yeah, yeah, true, very true. But then their data says there is absolutely no difference. Mm. Maruti Raja. Now we'll evaluate the left main first, see whether there is any lesion in the left main. So here the luminal area is good. It is 7 millimeters square. Okay, anyway, it's more than 10. Now that's the circumflex, that's the LED. Now we are going into the LED. There is significant calcification. Okay, here there is significant areas of volume reduction with at 6 o'clock to 12 o'clock position. It's been smooth, polished out. So this has really helped him. Now we'll go with balloon. We'll go distally till that particular area, till the septal branch. So that's the area of septal branch on angio co-registration. So we'll assess the length also from this area where the lumen looks okay. The vessel size is around 3. Then from there till the ostium of LED, it is 15 plus 15, 30, 31. So we go with 33 stent. We'll go with 33 stent. And so whatever we made out is, there is that particular area is significantly calcified, significant volume reduction has happened. I hope you can understand that, isn't it? That polished out areas, it's all those areas are all where the orbital has shaved off the calcification. Here again at 6 o'clock position, you are seeing a eccentric calcium wherein that has been shaved off because of the catheter bias, because of the wire bias towards this calcium. So that has been shaved off. So certainly we have a lumen now. We are able to dilate 3 balloon. Vishnu, 3 balloon. Now, so shall we go with the 333 stent? Huh? If you all had gone, then I would have done a route. We were planning for that. It would have been a bit more faster. Slow flow with rota is more. But then for this with an 1.5 bar, we would just finish off within 10 seconds. We would just finish it off so fast. So these sort of lesions you wouldn't encounter, mostly you wouldn't encounter any complication. Just because it's almost 30 millimeters long, we decided that rota would be the first option for this patient. But looking at the OCT, you can see that it's concentrated, the calcium is actually concentrated at one area alone. The rest of the areas the lumen looks good. The crown has done nothing over there. That is the most proximal LED, wherein the caudal view we saw that there was a tight lesion. That is the area wherein we saw significant calcium. In retrospect, certainly orbital has helped. When we see diffuse lesions, it's always rota. Jojo, show the 28 is enough. 33 open chedo. Did you open it up? No. See, when you want to see a reasonably good landing zone, see here, based on this, you can always look at this yellow box also. This yellow box, if you look at the yellow box, probably rather than this being a good landing zone, this would be a reasonably good landing zone. Hope you understand that. Now, looking at the yellow box, this would be a good landing zone. Now we'll measure the EL to EL at this particular area. When you look at the EL to EL from here till almost here, it's almost 3. So we can go with a 2.75 stent and then post dilated, but then we've already pre-dilated with the 3. We'll take a check shoot also and then the stent. So now looking at this is the 3 landing zone. 2.75 would be reasonable. Then coming more proximally, the vessel size is at least around 3.5 or so. So we would go with a 3 stent and post dilated. Then we'll once again check the length before we open up the. Did we open the stent? So distally, this would be a reasonably good landing zone, and proximally, this would be a 29. Oh. Okay, 30. Or even Vishnu, should we offer 20? If it is the advantage of 33 would be 1 millimeter into the left main and 1 millimeter distal. 33 would be preferable. 3, if you haven't opened a 3, 2.75 also will be okay, because distally it's a tapering vessel. 2.75, then we'll post it with 3.5. That's what we'll do. 2.75, 33. In diffuse calcium, see, no, actually he was mentioning, let's say she asked a question. Morning today we saw a case wherein it was only that LED D1 bifurcation. It was a very discrete, less than 10 millimeter length. So you are sure that it's orbital there, because it's a big vessel. It's a discrete lesion, 10 millimeter only. You know that 5 passes slowly or 8 passes very slowly, you would get a huge luminal gain. So you are sure about it. But here it's almost 30 millimeters. You are not sure where exactly you should be dwelling. The burr should be dwelling, or should we keep moving it up and down like this? So if you keep it moving up and down, the luminal gain will be very less. So when you see a diffuse lesion 30 millimeters or more than that, rota would be certainly better, I feel. Again, if somebody's got hemodynamic compromise, let's say the BP is around 100, 110 with some amount of LV dysfunction, people say rota is more dangerous, but I would feel rota you are done within few seconds. But here it's a compromise between the time, the luminal gain and the slow flow. If you are preferring for a much better luminal gain, you will ultimately end up having some slow flow. So again, that's a trade-off in this particular situation. So when it's a longer lesion, you are not sure where exactly is the heavy calcium like. A diffuse calcium, always rota would be preferable. But again, what is the length? We are not sure. The amount of confidence you have with rota and this. Distalo. Correct. Cranial. Show the cranial image. Show the cranial image. Should we not come back a millimeter? Vishnu, should we not come back a millimeter in the caudal? We come caudal. Epicaudal. Come to epicaudal. we should come back a millimeter. Okay, we'll take a proper cine. Yeah. Okay. I think we should come back another 2 more millimeter. This is 33 millimeter long. Okay, we'll come back and position it 1 more millimeter proximally. Okay, that looks reasonable. In case we miss the distal landing zone, we'll go with another string. I'll go up. We'll go up. Yeah, it's on the marker stand. Okay, 14, 16. Open eye Vishnu, Cine. Okay, negative. Come cranial, just come cranial. Once again, we'll dilate it and see whether it's fully open. The stent is fully open. Okay, again 14. It's open. 14. Negative. Okay, we'll take it. 3 and 3.5. Most proximally 3.5. Rest of the areas we'll go with 3. We can do that, but it's not a healthy vessel. It's a totally diseased vessel. Always perforation chances will be high. Anyway, we made out that it's 3, so we can safely go with a 3 at higher pressures. Cherry Ila, fluoro. Okay. Okay, distally it has landed really well. It is not in a disease segment. It's exactly there at the septal. Okay, 3 and 3.5, and we'll stop with an OCT pullback. And again, if you look in this view, the distal left main is also not very healthy. It looks smaller than the LAD only, smaller than the LAD. So we needn't be very aggressive. We will take a 3.5, but we'll go at lower pressures because anyway it's opening up. The vessel is opening up. Okay. 14, 16. Negative. 18. Negative. Again 18, 20. 18, 20. Negative. We'll take 3. Approximate. Okay. 18, 20, and now 3.5 below. Yes, anything is okay. 8 or 12. കഴിയാറായി വലിയ ബുദ്ധിമുട്ടില്ലല്ലോ. അതെന്ത് sinus exit block? It's exactly double that. Come caudal. More towards the left. Okay. Guide reposition. We push the guide. Okay. Okay. Small test. We'll see the stent properly. I think we'll go up 12, 14 and stop. 12, 14. Enough. I think we'll stop, do an OCT pullback. Some nitro. Can you come cranial? No, it's just that I don't, unlike everyone who does it through this port, I personally feel that in case you open it, whatever small clots are there, it will go into the coronary. So I always open this end and give it through this end. So when you connect it there will be a small air bubble. So just make sure that that air bubble is back into the. We can do that. Yeah, the same thing, it can be done. Okay, we are ready. Yes. 50-50. Good. We'll do final images and come out. Huh? Here they'll activate. Once you saw the clearing of contrast there, so while doing saline OCT, we can't say trigger, we can't say activate. So they'll be they keep looking at there, and once you see that the lumen is clean, they'll activate. Sure. Rotate it and show it to us. Rotate. Okay. Show the circumflex also. Rotate and show the circumflex. Rotate some. It's there. It's just 1 millimeter into the left main. Now show the bifurcation mode also. Distally, is there a dissection? Okay. So we are right at the circumflex ostium, 1 millimeter. This is what we would prefer to have most of the times, and show the distal end also. Distal end, whether there is any dissection. No dissection. Okay. Go distal beyond the stent. Once again, measure the EL to EL here. Okay. It's on 3. So we went with 2.75 and post dilated it with a 3. Vishnu, he's obese person, AP caudal. You won't get proper image when you go to RO caudal. AP, yes, that's good. That's wire കുറച്ച് pull back. Okay. Looks okay. That proximal lesion, at least it's opened up. The lumen looks okay. Distally, there is no dissection. Last shoot in the cranial. LED is flowing at the end of the day. Good decision that we'll go wire the diagonal rather than having the wire in the distal LED. Oh, we've already taken a crane. Okay, I think we'll stop. Bladder, show us the bladder. Ah, ah. That's why it is not well opposed at the area of the nodule. Bladder. We didn't give too much of contrast. No, we tried to. He had a baseline creatinine of 2. Now it's only 1.1. So we wanted to reduce them. No, we never do that. We never do that. Here at the end of the day, we might close this LED. So that's the only reason why. Otherwise, we never do that.